Hello and welcome. My name is Alana Gordon. I'm a reporter and producer at The World covering global health. And this is a Facebook Live Q&A about how US hospitals are confronting the coronavirus pandemic. And with me, Dr. Paul Bittinger, Director of Massachusetts General Hospital's Center for Disaster Medicine, coming to us from Massachusetts General Hospital. Hi, Paul.
Good afternoon.
And so MGH actually serves as a regional pathogens treatment center here in Massachusetts. And you can post your questions for Paul and me on our Facebook pages. That's at Forum HSPH and at PRI The World. Or you can email them to the forum at hsph.harvard.edu. And just to know that this Q&A is jointly presented by the Forum at the T.H. Chan School of Public Health at Harvard and The World from PRX and WGBH. And thank you for your patience. We are doing this on Zoom through Facebook, and we'll continue to bring updates to audiences about the coronavirus. So, Paul, a few weeks ago, we actually were at a panel discussing this new coronavirus outbreak. And at that time, you talked about how hospitals already pre-pandemic were at capacity. And so I want to fast forward and start to today with what you're most concerned about right now when it comes to hospitals in this current pandemic.
Yes, so much has changed from when we last spoke, and really the landscape looks so different. So certainly hospital capacity is always one of our biggest challenges when we look at anything related to disaster. But really my hospital and hospitals across Massachusetts, across much of the country, now have pared down to essential services. So all elective outpatient admissions, elective visits in the ambulatory setting, surgery has been canceled. And so my hospital, which typically runs well north of 90% in terms of occupancy, has been in the 60% range for about a week or so. And that's both a good and a bad number. 60% is a lot better than 90% in terms of what we expect we are about to see in terms of patient volume, but it does mean that we're still 2/3 full with necessary medical care. People unfortunately still, of course, have lots of normal medical needs, from happy things like childbirth to the more challenging things like heart attacks and strokes and others. And so really, when you ask me what I'm most concerned about, it's what's still coming. We are absolutely anticipating a large wave of patients, as we've seen elsewhere in the world, and really even just barely to our south in New York City. They're a week or two ahead of us. They're experiencing right now.
So we're going to get into depth because we've already gotten a lot of questions about some of these things, but I wanted to start with an overview. I mean, you mentioned that already you've cut, some services to prepare for this, but we're also at the same time hearing of a lot of shortages of personal protective equipment among healthcare workers. And I want to know what the situation and what you think can be done about that.
Well, it's truly an extraordinary situation, and we're trying to do whatever we can about it. Even a few weeks ago when you and I spoke, and there were very few suspect cases or confirmed cases in our area, we were already experiencing shortages of personal protective equipment. N95 respirators, which are the masks that we use to filter air that we breathe in if we're around a patient with COVID, an aerosolizing procedure like intubation or suctioning. Those have been on short supply since January before we ever saw a suspect case. Now, in addition to N95s, face masks, gowns, other medical equipment are in short supply. And so we really have had to go to extraordinary lengths. We have policies here at my hospital and across our system for extended use, where we allow staff to wear the respirators and masks longer than they normally would have otherwise, as long as they're not soiled, as long as they're not dirty. And we permit reuse, where, again, we have very special procedures for how someone can take off a mask, put a mask back on, so that it doesn't become contaminated, so that we don't expose the healthcare worker. But we are actually currently issuing one mask per staff person per day, and that's their mask that they have to use for the day, because we simply can't sustain any other strategy in terms of protecting our workforce.
What else can be done about the shortage? And when you think about this across hospital systems that are dealing with the situation you are. Mass
Sure.
General is, yeah.
Yeah. So certainly it's our hospital, but it's the system I belong to, and it's really all hospitals. We're all in this together in a similar boat. All of us have extraordinary supply chain staff who have been working extremely long hours, working with every vendor, every manufacturer, every distributor they can find, both in the US and abroad. And they're doing their best they can to maximize capacity. But there are innovative things. I think it is interesting to see what is happening to try and adapt to the situation we face. There have been 3D printer recipes out there on the web to make face shields. Those may be the easiest for us to do. Clear plastic face shield that covers the whole face, but also masks and maybe even N95 respirators. And an N95 respirator is a reasonably complicated piece of equipment, even though it doesn't maybe seem it, but it has to filter out things down to a size of about 0.3 microns. And so to make sure that we can make it, but then know that it actually is effective, that it's going to protect our healthcare worker, those are the things we have teams of scientists literally as we speak working on and testing right now to try and validate.
This question comes from online. Would something like the Defense Production Act make a difference soon?
So I think soon is exactly the right word there. Unfortunately, where I am here in Boston, we think that we may be 3, 4, 5 weeks away from our peak wave of illness, which means we have very little time to adapt. So absolutely, I think if there are factories, if there are manufacturing ways to be able to get us appropriate quality personal protective equipment for masks, for gowns, for N95 respirators, for face shields, we absolutely need it. And we're behind a couple places in the country, but we're ahead of others. And so I think the time to ramp up that manufacturing is right now. But any solution that's going to take 3, 4, 5, 6 months is probably going to unfortunately not help us in time.
This question is from someone also named Alana, like myself. Are any sterilization techniques being explored, whether that's like UV treatment, heat treatment? Is that effective?
So it can be effective. The University of Nebraska just shared a protocol that they have been using to use UV sterilization for especially N95 respirators. We're testing that again ourselves. This is an unprecedented time for everyone sharing scientific data. So it may actually be effective, and we may go with large-scale UV irradiation. What we need to know is that if we do that, not just the mask or the respirator, but actually the rubber band or the way in which it attaches to the user also maintains its integrity. We can't, of course, have the rubber band snap halfway through and expose the wearer.
This goes back to the masks, but we've gotten several questions, so I want to ask it, which this one is from Laura from the Nurses Health Study. I've started to see efforts organized of people sewing face masks in response to shortages. Is that worthwhile? Is there guidelines for it?
Yeah, so 2 things I would say. One is there's been an extraordinary outpouring of support from everywhere around the community, and people offering to sew and to do anything they can. And I have to say, I see that as a very positive sign of how people are willing to help protect the healthcare workers in their community. That being said, boy, do I wish I didn't even have to consider that making our own personal protective equipment at home in this day and age seems really like something we wish we didn't have to think about. What I would say is that when they've been studied in the past, homemade face masks have not performed similarly to professional face masks, and so we're trying very hard to work with things that are either already specifically manufactured or maybe custom designed with 3D printing others to give us a level of confidence we know. However, I will note that there is CDC guidance that says that if there's truly nothing else, one can consider face masks. So I'm not encouraging folks to do a lot of sewing right now. We're trying everything else that we can come up with, but I hate to say it, we're in a situation where we don't want to leave any option off the table going forward.
You mentioned about like here in Massachusetts, or how you're feeling like they're for 3, 4, 5 weeks from a peak here. But again, this is for hospitals and the theme across the US. This question comes from GP. Disaster risk reduction experts talk about emergencies in 3 stages. So you have preparing, managing or mitigating, and then recovery. So for something like this, if we're trying to spread things out, slow down the tsunami of infection, after this wave does peak, can we expect the recovery phase to last many years? How long will this tail be? I know it's kind of a projection, but what are
Yeah.
we in for?
No, it's so hard to predict, but it's a great question. I think, we expect that this wave may last 3 months, give or take. It's so hard to know for sure, but it's going to take a while. With previous pandemics, we have seen later waves that are delayed by a number of months. So even in the 1918 pandemic, the worst influenza pandemic we saw, there were multiple waves. So one might expect that if we get through this wave, there could be additional waves after. I think, so much is unprecedented with this particular outbreak, including how much asymptomatic transmission there is, that there are a good number of people who don't have either any or very significant symptoms who appear to be infected and unfortunately are transmitting disease. There's some good news, of course, that it's good that people have mild illness. There's bad news that they're transmitting disease. What it means is that we're going to have to figure out as we get through this wave how much of the population has immunity. Because ultimately, whether we see another wave and how big that wave is going to depend on how much immunity there is in the population. If it's 70, 80% immunity across the population, we may not see much of a wave, but it's unfortunately way too soon for us to test. And we're going to have to do some blood testing, some other ways to start to get a handle on community immunity before we can make that kind of a prediction.
It's just really surprising to me how quickly hospitals are already so strained. And I just have to kind of pause and wonder from an emergency preparedness perspective, how this is, given how much we talk about preparedness. And I just wonder if you could offer a little bit more on that.
Yeah, no, I mean, I think this is something that so many hospitals, myself, my hospital included, have been preparing for years. Again, I think you and I spoke when we last met about the fact that since the early 2000s, when people saw bird flu H5N1, we talked about pandemic planning. We talked about 1918-like scenarios, which were very severe. And I think there has been an awful lot of work. But I think, it's honestly very hard for most people, maybe all people, to understand the concept of geometric rise in the number of cases. And, this is a disease that is spreading that way, that one person infects between 2 and 3 people and the cases double, therefore every 2 to 3 days. And when you get to the steep part of the curve, once you start seeing sustained transmission in the community, seeing cases go from 10 to 20 to 40 to 80 to 160, that those numbers don't seem so bad at the beginning, but then quickly when you double every 2 to 3 days, it gets overwhelming very quickly. And evidenced by the fact that New York City, or New York State, I believe, has 25,000 cases just now.
So we were getting a lot. I just want to pause to take that in. I want to ask some clinical questions that have come up from healthcare workers and doctors. This one comes from Todd, who's a doctor in New York City. And this question comes from kind of varying guidance, differing guidance that they're getting. But the question is, and you mentioned that there is still some care going on in your hospital, but what's the role of non-urgent but emergent medical treatments like cancer surgery in this environment? So it's certainly an issue, he says here. There's still patients coming in for chemo. And it's a situation where the questions come up where should we be wearing personal protective equipment on screened but COVID status unknown cases for non-emergency surgeries? And also, like, places like the American College of Surgery still recommend most cancer surgeries can proceed now. So I think these are some of the hardest questions. No doubt about that. I think, certainly there is no circumstance where we only want to deliver care to COVID patients, right? Our whole job as a medical system is to do the best we can with the resources we have for the most people. And we want to save lives in cancer, in heart disease, in stroke, and in infectious disease. And so we have to prioritize our care by the way we save the most lives throughout all of this response. For our own system, we don't make a blanket statement about cancer care. Certain kinds of either cancer surgery or chemotherapy or other interventions relate to the consequence of not doing them. So certain people with different kinds of
tumors or conditions, absolutely need to proceed. If they have a tumor in their abdomen that will produce a bowel obstruction, that if we don't take it out right now, basically is life ending, but we can alter that course, that person would be in a high priority criteria for us. But there are other folks, again, these diseases have quite a spectrum, and we're clearly delaying a lot of care where we can safely. So I think that this is absolutely hardest to try and figure out how to apply these criteria. I would say, for years we've been approaching this topic with a set of rules that very much still apply, is that they have to be fairly applied across all patient populations. They have to be ethical, they have to be evidence-based, and so wherever possible, when we're trying to make these very, very hard decisions, we rely on a scientific database, and that we're ourselves quite transparent about it, so that we share with our workforce and with our patients how we're making these decisions, because they're hard, but we have to make sure that we preserve confidence in the medical system.
This question, we've gotten a few questions about pregnancy. And so I want to ask about, and those, it seems like very difficult questions and determinations to be made. It seems this one's from online. I'm going to combine two in one, and this other one is from Betty McNally also. It seems to me that we should be moving patients like mothers who are delivering to separate facilities, and putting all the coronavirus patients in hospitals. Is this conceivable or practical? And the other part of this is what precautions are in place for women who are pregnant during this time? Sure.
So obviously it's very, very normal and very appropriate to worry about pregnant women at this time. I hate phrasing it as good news, but it's at least not bad news that there's no evidence to suggest that pregnant women are at greater risk than the rest of the population. So far, when it's been studied, there has not been maternal fetal transmission of the virus noted. And so unlike influenza, where unfortunately back in 2009, during the H1N1 pandemic, there was a specific higher risk for pregnant women, that appears not to be the case so far with COVID-19. So a small glimmer of hope with that. In terms of trying to create separate facilities, it's a question that comes up a lot, and I think certainly I understand why. Given how much asymptomatic transmission there is, we have found cases of COVID infection in people that had no respiratory symptoms but did have other medical problems, meaning a stroke or an appendicitis or actually pregnancy. And so it's just not possible to create an entirely separate facility where you can guarantee that no patient, no staff member has been exposed to COVID or may have symptoms of COVID. And so I think what we try and do is make sure we do our very best infection control procedures everywhere. And one of the things my system has done really to adapt to this problem or this challenge of asymptomatic transmission is we now have our entire workforce wearing a mask the entire time they are at work. And that is both in case the patient is asymptomatic but infected and has a different presentation. And it helps our patients, including our pregnant women, to make sure that we are protecting them equally. So we're constantly looking at everything that we can to reduce disease transmission. Clearly, we want to be a safe environment for all patients. But right now, there really wouldn't be a practical way to create a separate facility for pregnancy.
All right, and are you in a place where it's set up where everybody, hospital workers in particular, are able to be tested for coronavirus? If you're having this issue with asymptomatic, some shortages of protective gear, and we know from other places like Italy that the hospitals and healthcare workers want more protection and want more support to make sure they're not spreading it to their families, but also to others in the hospital.
Absolutely. So again, I think everything that we've been doing is about that safety in mind. It's part of why, again, we've moved to this mask policy that we have right now. I think it is not, it's certainly not possible, it's not practical to imagine testing all of our workers every day. And a negative test today doesn't mean that you couldn't have a positive test tomorrow. You look at a hospital like mine with 26,000 people, it's just not possible to test every single person, get those results back. What we have done is we've pushed out extraordinarily broad guidance that people shouldn't work here, even with the mildest of symptoms. We've seen people that have a mild sore throat, a little bit of aches, so not even quite a fever, but just don't feel good. who end up later having COVID. And so we have pushed out guidance to all of our employees to stay home and then to get tested if they have even what they think is just a little symptom that they never would have stayed home from before. And I think today, actually just this morning in one of our meetings, we reviewed data that show that only 1 in 10 of our hospital staff that are being tested end up having the disease. So that means that they are having an incredibly low threshold to get tested, even again, that they're a little achy. We encourage that, and they stay out of work to protect our facilities. So, you know, our staff have risen to the occasion. It's been extraordinary to see what our nurses, our other staff are doing, and they take the safety of their patients extremely seriously.
Just for a bit of a deviation, Kim asks, how long after I've recovered do I need to keep myself quarantined, I guess it would be, or isolated so as to not infect others? And I'm sure that goes for health workers too.
Sure. This is a thorny question we're trying to dive into with the science. We know that actually we can test workers and find COVID virus for sometimes weeks after they have become infected. And this is data from Italy and China and elsewhere. Now, it's not clear that people are still infectious. If we stick a swab in somebody's nose, our genetic amplification techniques are so sensitive, it may be possible to pick up the virus even if that person is no longer infectious. So we're trying to do epidemiology right now to answer that question. Clearly, what we do is we go very conservative. So right now, what we've been doing is a combination of duration of symptoms. So we make any worker who's tested positive be asymptomatic for 3 days. And then right now we're doing repeat testing to prove that they're negative. Whether we're able to sustain that or not, we'll have to see. But clearly, there's, you know, our priority is making sure that we don't have healthcare workers transmitting disease.
And 3 days is the CDC guidelines right now of no symptoms. The
that
WHO, it's a little bit longer, I think, than that.
Okay, so that I wouldn't know off the top of my head. You may be right. I would say it's very different than what we do with normal upper respiratory illness, where traditionally across the healthcare system, we've said 24 hours without a fever or symptoms and not taking any fever medicines, then you can come back to work. But we're definitely trying to take a very cautious approach.
So there are a lot of questions. So I want to see, what are your thoughts on the antibody test? Is this something that could potentially be used to mass deploy testing and better understand these questions that you're talking about down the road, and how soon?
Yeah, how soon, I don't know. I'm certainly looking to my colleagues in the lab world to answer that, because I think we need it as soon as we possibly can. I think when we talk about community immunity, as we were saying before with the wave question, we are going to need that antibody test to be able to answer that question. I think across the healthcare workforce in the US, there probably are people who have been exposed and infected who don't know it because, again, of the degree of asymptomatic illness. So I think what we're going to need to do is test our whole healthcare workforce for evidence of immunity, let them know whether they've been infected or not. But I think we need to test broadly across our communities to give us a sense of how many people have yet been uninfected and what we need to do to interrupt that chain of transmission.
So here's another question, and it comes more from outside hospital settings, but this comes from Anjali Nath with the Boston Health Commission. The average person is grabbing everything they can. And she says, I'm concerned that people are using or are being exposed to cleaning products more and increasing their risk or worsening existing health issues like asthma. So can you provide any more specific guidance on the science behind COVID-19 and what soap does to break it down as opposed to these other cleaners and disinfectants?
Yeah, and you know, I certainly understand everybody's fear and anxiety at a time like this, and that's normal that people are feeling anxious. And the best way, as always, to combat anxiety is with knowledge. You know, unfortunately, there was I believe, a story today about two people, a husband and wife, who were injured. I believe the husband died from trying to treat themselves with fishbowl cleaner that had chloroquine in it. So, you know, trying to make up remedies or treatments is bad. And I think trying to to do more than what is recommended right now for household cleaning is unnecessary for exactly the reason that your writer suggests. I think,
So
what we
can you just clarify what the guidance is? Is
yeah,
it?
absolutely.
Yeah.
So any cleaning product that is FDA approved with antiviral action, generally speaking, is approved. You can look on a CDC website. You can look on the FDA website to find a list of specific products. But even though the virus can live on surfaces for hours, in some circumstances, days in others, normal cleaning products, again, the ones you would buy that are actually already FDA approved, generally speaking, do a great job. Soap and water does a great job of cleaning your hands. And so, again, and we might have actually talked about this last time as well, but it seems silly to ask people to go watch a YouTube video about hand washing. But most of us don't wash our hands well. To learn how to make sure you cover your whole hands with soap and water, make sure you do it for 20 seconds. That works quite well, and you don't need dangerous products or other home remedies beyond normal hand washing to keep your hands safe.
I want to get back to a question from online, which spoke a little bit when we were asking about treating pregnant women elsewhere. But is there conversations across hospitals, and do you see any opportunities in this or concerns about using things like empty dormitories near hospitals to expand capacity and function as emergency treatment centers?
So we're certainly looking at all of our surge capability options, again, both because of the amount of critical illness we think we may have to care for in hospitals and the the level of what we call floor level illness or general medical unit illness. There is a possibility that either to treat that illness or as folks are improving from their COVID and they need to be discharged out of the hospital to appropriate facilities that we may see some overload. Many of our skilled nursing facilities, our long-term care facilities, are concerned about the possibility of patients recovering from COVID, and that can create an outflow obstruction within the healthcare community that will cause challenges for us. The issue with dormitories or hotels, obviously, is that they're non-medical spaces. They're not set up for monitoring for medical gases. They often don't have the wireless supports and systems that we need for our electronic medical records. So they're not necessarily off the table, but they're not ideal, especially dormitories with common bathrooms create special hygiene challenges for infected people as well. But we're looking at all options. Certainly, I know in a couple parts of the country, the Army Corps of Engineers is building tent hospitals, and you can build larger facilities. I want to give the city of Boston and the Boston Healthcare for the Homeless group a lot of credit. They've been putting together some tent facilities that support our homeless community. Because they are absolutely at risk. There are some really clever ideas going on, may or may not involve dormitories and hotels, but everything's on the table as we look at the number of patients we have to care for.
I want to get to this question from Edric. What about health workers themselves who are more senior with comorbidities themselves? What are your recommendations for healthcare staff? Stay home versus report for duty? How are you handling that amongst your own staff, and what recommendations do you have?
So I think among the healthcare workers in the workforce that we have, there's quite a range of different reasons why people might be at higher or lower risk. And so we have pushed out guidance to our managers that we work with our occupational health experts. We try and come up with an accommodation that is appropriate when possible. Clearly we do need people to work, and we need to offer them the right personal protection in order to let them work safely. If we're concerned that either the worker's risk is too high or the ability to use personal protective equipment is insufficient, then we definitely have to try and make an accommodation. But trying to do this equitably is really important. I'll say this specifically as a physician. Sometimes it's easier for physicians to work remotely to deliver telemedicine. And some of our janitorial or food service or security or other staff have to be here to do their jobs physically. And what we're trying so hard to do is, number one, keep the minimum number of people here at the hospital that we can to do our work safely, but also be equitable so that each of us is being treated fairly in terms of how we're exposed to the risk from COVID as we support the hospital and its operations.
Finally, we have a few minutes left, but I wanted to switch to, and I hope we can continue this conversation about the ethics. I'm curious how that's changing for you and others, and the dilemmas that you're facing and what that's bringing light to. But your Mass General and other hospitals are treating patients that have coronavirus, and I want to hear a little bit about. And we've been getting questions about what you're learning about patients who have this actual disease, COVID-19. One question comes from Matt about there's been anecdotes about people losing a sense of smell or taste. Can you tell us about what you're seeing in terms of treating patients and what that looks like?
Yeah, so our experience has actually fit what's been published so far reasonably closely. There's good news in that, which is probably 80% plus have had mild illness, have not needed hospitalization, have been able to isolate at home safely, and have recovered from their illness. And so I do want to say that's definitely part of our lesson, and there's good news in that. We are, of course, unfortunately also seeing people who get hospitalized, and some with critical illness. Many of the people who get sicker tend to do so at about a week or so into their illness, a little after. And so that's a challenging time. We've seen about half of the people that we've had to hospitalize need intensive care. Many are currently on ventilators, some on our most intensive ICU interventions in order to support their course. We are participating in a large number of research trials. We are trying to offer and study hydroxychloroquine or chloroquine when appropriate with azithromycin. Remdesivir is a viral trial that we are participating in a multi-center study on. I certainly understand everyone's desire for a quick answer about what's the therapy that's going to work, but we are trying really, really, really hard to follow the science, to produce the science that will let us make good decisions. Unfortunately, in the history of medicine, there are a lot of therapies that have seemed like a good idea based on a few anecdotes that turn out not to be good ideas later. What we need is good data sharing. And so we're clearly working with other hospitals in the Boston area, but we're participating in national collaboratives so that we can pool our data and learn these lessons as fast as we can. I would say about the folks in the intensive care unit, certainly, again, the people we need to hospitalize have been older on average than the people that we have not needed to hospitalize. But as has also been reported, we have younger patients with critical illness, and really there is risk for just about everybody.
That's really fascinating to know the way that you're kind of triaging or figuring out treating patients, because there's been a big rush on these drugs and excitement about it. And it sounds like you're looking to set up and provide those treatments, but in a way to study it and in a more clinical way of not putting too much on it. Yeah,
I mean, like everybody, we want to be hopeful. We want to find a therapy, but we also want to make sure that we're not harming people or giving them false hope in the process. So as this outbreak progresses, the way we're going to do this is with good pooled data. It's basic statistics. You need a large enough number of patients to know that your therapy is working. But we're going to try and do this all together so that it doesn't have to be one by one. As a hospital, we learn these lessons.
We're just about out of time, but I want to ask you this final thing. We started the conversation with a lot of questions about what concerns you, but I wanted to ask you what you're hopeful about.
I am hopeful that there is good in human nature that we're seeing even in these challenging events. I've never been more proud to be a part of the hospital community, seeing how our nurses, our food service, our security, our materials management staff step up. Is truly heroic and is kind of invisible to the outside world. They show up incredibly early. They stay late. They are concerned about their health like everyone across the country, and yet they show up and do their jobs. I also think it's extraordinary what support we've received from the community. I've heard from, again, many of our nurses, many of our other healthcare workers, that people are reaching out to them saying thank you. They're just giving them a little call or an offer of support. With all this social distancing, I think especially in the medical community, we're at risk of social isolation, that people feel like they're on an island, sometimes cut off from their normal support networks. And I think what's been extraordinary is to see how everyone across the community has been reaching out and just trying to make sure that they get us through. And I'll say from my side, it's extremely well appreciated. those little texts, those little phone calls, those little FaceTime meetings mean something, and it's nice to see.
Well, Paul Bittinger with Massachusetts General Hospital, thank you so much for joining us this Facebook Live Q&A. We hope to continue the conversation through the Harvard T.H. School of Public Health at the Forum, and also this with the world, brought to you by PRX and WGBH. So thank you so much for your time, taking time out of your busy, busy day with all of this. And again, we hope to continue the conversation online on our Facebook pages. And you can also tune in for another Facebook Live on Thursday here at the Forum. Thank you.
Thank you, Lana.